Good morning, everyone, and welcome to the Department of Medicine Grand Rounds. In the interest of time, let's go ahead and get started. It is a true honor to introduce my colleague and friend, Dr. Ryan Westergaard, as today's Grand Round speaker. Ryan has been with our Division of Infectious Diseases since 2011. Prior to joining us, he completed his fellowship in infectious diseases at Johns Hopkins University and his residency in primary care internal medicine at the University of Colorado. He earned both his MD and Masters of Public Health degrees from Johns Hopkins and later returned to Johns Hopkins School of Public Health to complete a PhD in clinical investigation. Ryan's whole career has been dedicated to working at the intersection of clinical medicine and public health. He is well known in Wisconsin as public health physician leader. Ryan has served as a chief medical officer and state epidemiologist for communicable diseases since 2019 and played a pivotal role in our state's response to the COVID-19 pandemic. Ryan is a prolific researcher whose work has been consistently supported by federal funding throughout his career. He has secured numerous prestigious grants at the federal, state, and local levels. His scholarly contributions include 144 peer-reviewed publications, over 60 research presentations, and co-authorship of more than half a dozen book chapters. Ryan has also been a dedicated mentor to countless graduates, postgraduates, and professional trainees. His outstanding work has earned him several notable honors, including the NIH Director's New Innovator Award for research on HIV and AIDS, HIV Medical Association's Investigator Award, recognition from Infectious Disease Society of America, and the Fulbright U.S. Scholar Award, among others. As the pandemic begins to wind down, Ryan revisited a long-held dream of spending a sabbatical year in sub-Saharan African country. We reached out to our partners in Rwanda, where our global health program has recently expanded, and the opportunity quickly took shape. Thanks to our strong partnership with the Ministry of Health of Rwanda and the leadership at the King Faisal Hospital, and his successful proposal to secure a Fulbright Scholar Award, the idea becomes a reality. Unfortunately, though, just a month after relocating to Rwanda, and I might say with his family, another public health challenge has emerged, an outbreak of Marburg virus disease. As it turns out, the epicenter of the outbreak was the very hospital where Ryan and his wife, Mary, began their work. In his presentation today, Ryan will be sharing his experience as a Fulbright Fellow with the Ministry of Health of Rwanda, where he shared his expertise as an ID specialist and clinical researcher with Rwandan health leaders during the outbreak response. His expertise and dedication were deeply valued by the ministry and by those who had the opportunity to work alongside with him. And with that, Ryan, take it away.
Good morning, everyone. Thank you, Dowd, so much for the lovely and very informative introduction. As Dr. Dowd mentioned, I'll be sharing my lessons from my year in Rwanda, where I served as a Fulbright Scholar with the Rwandan Ministry of Health during the country's first Marburg outbreak of Marburg disease. So I have no financial conflicts of interest to disclose. I will be discussing investigational and unapproved treatments for Marburg, including remdesivir and monoclonal antibodies that are still under investigational status. These are the official learning objectives for today's session. First, we'll look at how the 2024 Marburg outbreak in Rwanda unfolded, what it looked like clinically and epidemiologically, the diagnostic and infection control challenges as presented. Second, I'll describe how the Rwandan Ministry of Health and its partners were able to launch therapeutic and vaccine trials within days of the outbreak, and what that experience means for the future of outbreak-related research. And finally, I'll close by reflecting on the One Health framework and how strengthening clinical training, laboratory capacity, and public health collaborations together can help prepare us for whatever emerging pathogens come next. To set the stage, geographically speaking, Rwanda is a small landlocked country in East Africa, bordered by Uganda, Tanzania, Burundi, and the Democratic Republic of the Congo. It's about the size of the state of Maryland, the population of about 13.5 million people. The capital, Kigali, where we lived, is shown here in the center of the map. It's home to about 1.7 million people. It's an incredibly beautiful country. It's known as the land of 1,000 hills, and as I learned, has excellent bird watching too. It has a young population, quite densely populated, and as we'll see, a remarkably well-organized public health system. As Dowd mentioned, I was in Rwanda with the support of the Fulbright Public Policy Fellowship Program. So this was a year-long sabbatical from UW-Madison, and from a year-long leave of absence from my role at the Wisconsin Department of Health Services. And this allowed me to be embedded full-time with the Ministry of Health, specifically with the Department of Health Workforce Development. My role there was to learn from colleagues, support various ongoing initiatives, and strengthen partnerships between Rwanda's health institutions and our ongoing academic collaborators here in Wisconsin. This was also very much a family adventure. My wife, Mary, who, as many of you know, is a professor of emergency medicine here at UW, and I planned to spend the full academic year in Rwanda with our 3 teenagers. Planning for a year abroad itself was logistically quite challenging. It took us many months. Here you can see on the left us leaving Madison, then departing O'Hare Airport, and then arriving in Kigali some 30 hours later. But once we settled in, we took on academic and clinical teaching roles. All our kids enrolled at the International School of Kigali, and we were ready to get to work. So starting in August of last summer, both Mary and I joined the team at King Faisal Hospital as volunteer faculty, which was in addition to my role at the Ministry of Health. KFH is a rapidly growing academic tertiary care hospital. And just months before we arrived, Rwanda had launched what I believe is still the newest medical school on the continent, called Africa Health Sciences University, with King Faisal serving as its administrative and clinical headquarters. Mary was helping to launch the first cohort of emergency medicine residents, which was one of 6 brand new residency programs that started in July. And I had similarly planned to support the final stages of accreditation and recruitment for the Rwanda's first infectious disease fellowship. And this was a years-long effort that was Dowd Siraj and Dan Shirley from our division of ID had been helping to build for some time. The story of the Marburg outbreak really begins here, with 2 patients admitted to the King Faisal ICU, literally within hours of each other. Their illnesses, which I'll describe very briefly, prompted the first serious questions that something unusual and highly concerning was happening. The first patient was a 24-year-old man who came to King Faisal Hospital with several days of fever, chills, and headache. On admission, he was febrile and appeared ill, with conjunctivitis and abdominal tenderness on exam. His initial labs showed markedly elevated transaminases and LDH, rising bilirubin, but initially normal creatinine. He was started on empiric treatment for the most likely causes of severe sepsis, but over the next several days, he deteriorated quickly, developing confusion, then acute kidney injury, shock, and respiratory failure, requiring intubation. The second patient was admitted to the ICU just less than 1 day later, a young man also previously healthy, with a nearly identical presentation of high fever, abdominal pain, progressive confusion. His laboratory findings showed the same pattern of liver injury, also thrombocytopenia, and he also had rapid deterioration despite broad spectrum antibiotics and supportive care. Seeing these 2 severe unexplained cases so close together raised alarm that we might be dealing with something new and something much more serious than routine sepsis. The experience of caring for these 2 patients in the ICU was described beautifully in this first-person essay by our colleague, Dr. Sivamana, one of the intensivists at King Faisal Hospital, who was on duty when the 2 of them were receiving care. His account that conveys what it felt like in that moment, and I'll read a short quote from his essay. Given their significantly reduced oxygen saturation, I decided to intubate them to protect their airways. I asked the on-call anesthesiologist to intubate the second patient while I intubated the first. I opened his oropharynx with a laryngoscope. I observed that the source of bleeding was not the oral cavity, but rather the esophagus and airway. I was immediately filled with fear and anxiety regarding the possible cause. So what was the possible cause? Given the severity and the rapid progression, the infection control team at KFH raised the possibility of a viral hemorrhagic fever. and blood samples from 4 patients, including the 2 I just described, and unfortunately 2 other hospital staff members who had developed severe illness around the same time, were all sent to Rwanda's National Reference Laboratory, which has the capacity to test for a panel of multiple pathogens known to cause VHF. We learned on September 25th that the initial tests were negative for Ebola, Rift Valley fever, and dengue virus. We learned 1 day later that Marburg virus RNA was detected in all 4 patient samples, confirming what would soon be recognized globally as Rwanda's first outbreak. Here's some background information on Marburg virus. It belongs to the family Filoviridae, the same family as Ebola virus, and causes a severe hemorrhagic fever with traditionally high case fatality rates. It was first discovered in 1967 after laboratory workers in Marburg, Germany, developed hemorrhagic fever following exposure to African green monkeys that were imported from Uganda for research on polio. 31 people were infected in that initial outbreak, which provided the first clues about the clinical syndrome caused by this family of viruses, as well as the virus's morphology and transmission. And the electron micrograph here shown on the left is from that actual first 1967 event. And the shape of it gives the family of viruses its name, philo, which means thread-like. Marburg virus targets the cells of the immune system, macrophages, dendritic cells, and endothelial cells, leading to early immune suppression and uncontrolled viral replication. The virus then spreads to the liver and spleen, infecting hepatocytes, which cause hepatocellular necrosis, impaired coagulation factor synthesis, and thrombocytopenia. The infected immune cells produce a cytokine storm, triggering disseminated intravascular coagulation. There's increased vascular permeability, leading to hypovolemia and shock, followed by multi-organ failure, especially of the liver, kidneys, and adrenal glands. This cascade explains the rapid transition we observed clinically, starting from non-specific febrile illness to fulminant multi-system collapse. The natural reservoir for Marburg virus was identified decades after that first outbreak, and it is the Egyptian fruit bat, shown here in the image on the left. It's a fairly common species found throughout sub-Saharan Africa. The bats carry the virus without becoming ill, and they roost in large colonies in caves and mines, which are environments that occasionally bring them in close contact with humans. Nearly every known Marburg outbreak has been linked to sites where these bats live, as you can see in the figure on the right. So when we think about Marburg virus, we're really talking about a zoonotic disease, one that emerges at the intersection of humans, animals, and the environment. The table shown under the map from the same review article highlights the historically high mortality rate for Marburg virus. The largest outbreak was in Angola in 2004. In that outbreak, 90% of the 252 cases died. The second largest outbreak was in the Democratic Republic of the Congo. There was an 83% mortality rate among 154 cases. Most of what I've discussed so far, and then we'll share shortly, including the outbreak detection, the clinical course, and the early public health response is nicely summarized in this paper, which our Rwanda team published in the New England Journal of Medicine a few months ago. The paper highlights the broad scope of their response, from the rapid case investigations and contact tracing to infection control and treatment in the treatment center, and then the introduction of investigational therapeutics, genomic sequencing, and ecologic surveillance. The publication was a huge team effort. Everyone was very proud and excited, and it represents the collective work of dozens of Rwandan scientists, colleagues, and public health leaders who coordinated all this work in real time. Once the outbreak was confirmed, the Ministry of Health activated the National Command Post, which is a structure that brings together all sectors of government and the healthcare system to coordinate the response. It was modeled after the COVID-19 response framework and organized around the 9 technical pillars shown on the slide, from leadership and coordination to surveillance, laboratory, case management, infection prevention, vaccination, logistics, and risk communication. I can't go into all 9 pillars today, but I will highlight the 2 areas where I had some direct involvement. First, the surveillance systems, including case detection and contact tracing, and the clinical management and vaccination activities at the treatment centers. Rwanda's outbreak surveillance operated on several layers that worked together simultaneously. At the top were rapid response teams, which were trained clinicians and epidemiologists who investigated every suspected case, coordinated contact tracing in real time. At the health facility layer, they implemented universal symptom screening and triage at all emergency departments and outpatient clinics. Thirdly, a community-based layer extended this reach, where community health workers went door to door, screening households, educating families, and identifying anyone with compatible symptoms. And then finally, there was an additional mortality surveillance component, where all community deaths during the outbreak period were tested for Marburg virus at the National Reference Laboratory. I'll provide some brief details about how these first components were implemented, and then go into some greater depth describing one specific investigation that I found particularly fascinating and instructive. Within days of the first case, contact tracing teams were mobilized nationwide, though much of the early focus was here in Kigali around King Faisal Hospital cluster, and they worked around the clock to identify every possible exposure to the initial cases. The figure that you see in the slide here comes directly from a situation report shared at the National Command Post. It shows the progress during the first 7 days of the outbreak. Starting in the lower left, from the initial confirmed cases, each day brought hundreds of newly identified contacts who were required to monitor their symptoms daily using a mobile phone app that was first developed during the COVID-19 response. But this same figure also shows something much more sobering and frightening, which is the number of newly symptomatic contacts, many of whom tested positive and required hospitalization. In that first week alone, more than 25 new Marburg cases were confirmed, most of them among healthcare workers, and 7 of them ultimately died. This was the week that Mary and I made the decision for her to take our kids home to Wisconsin, while I stayed in Kigali to continue working with the response teams. It was a difficult decision to make, but by then the risks to healthcare workers were unmistakable. We didn't know yet whether there would be broader community spread, and so getting the family home to safety felt like the obvious right choice. As contact tracing intensified, the Ministry of Health expanded symptom screening, testing, and triage to health facilities in every district in the country. And what you see here corresponds to Table 1 in the New England Journal paper, which is a summary of the national screening effort from September 23rd through November 22nd. So during that period, 6,340 suspect cases were tested and 66 were confirmed positive. The vast majority of those were among healthcare workers. These numbers reflect how quickly the surveillance infrastructure scaled up from just a few hospital clusters to a nationwide network linking clinics, laboratories, and community health workers in real time. Alongside the contact tracing and the national testing strategy, there were 2 additional surveillance measures that I wanted to mention. First, there was door-to-door symptom screening carried out by the about 60,000 community health workers that work in Rwanda in all 30 districts. Over just a few weeks, they visited more than 1.2 million households, reaching nearly 5 million people to check for fever, or bleeding, or other concerning symptoms, and also to provide health education and information about the outbreak. At the same time, the Ministry of Health implemented a mortality surveillance program, which required Marburg virus testing for all community deaths occurring during the outbreak. And in that effort, 240 decedents were tested, and none, fortunately, were positive. So these 2 layers were enormously reassuring. They showed that while transmission had been intense within healthcare facilities, there was no evidence of undetected community spread. So by early October, the surveillance systems that I just described had found no evidence of ongoing transmission outside the hospital cluster, which, as I said, was reassuring. But one crucial question still hadn't been fully answered, which is where exactly had it started? So the focus of the investigation expanded from merely containing the outbreak to trying to understand its origin, to reconstruct as precisely as possible the earliest chain of events. So this diagram shows the first working sketch of the transmission map that was developed during the initial investigation. It's a complex figure, but I wanted to focus your attention first on the 4 red asterisks. These mark the first 4 laboratory confirmed cases. And the question investigators first asked was what did these first 4 patients have in common? it was determined that all four had contact with an earlier patient at King Faisal Hospital who had died on September 9th from a severe febrile illness, but in whom viral hemorrhagic fever had not been considered at the time. That individual, who you can see is labeled C00 in this figure, became understood to be the presumptive index case and was the central focus of the ongoing community investigation. The diagram also shows how by the end of the first week, a large cluster of illness had emerged among staff at King Faisal Hospital, as well as secondary transmission to the family of the index patient and also to a second hospital, which was where one of the physicians who were exposed at King Faisal had also been working when they started to develop symptoms. So this was not a single exposure event, but rather the first evidence of a multifocal outbreak that connected hospital, household, and community settings. So as the investigation continued into this person that I called the presumptive index case, there was no evidence found that he had been exposed to any other ill contacts or a known wildlife source, such as bats or non-human primates, who are also known to carry the virus. So the absence of an obvious exposure raised a new question, which was, had we actually found the true first case? So to explore that possibility, I was invited to join a small team of physicians to conduct an in-depth retrospective review of hospital records, focusing on patients admitted to King Faisal and neighboring facilities in the weeks before the first recognized cluster. We used a standardized case definition, the same that was pushed out for the national screening and triage effort. And we screened hundreds of charts for compatible symptoms, laboratory abnormalities, and unexplained deaths. We started on a Friday night and worked through the weekend, taking breaks to eat and sleep. We set up in empty exam rooms and combed through electronic medical records and entered each case we found into a shared spreadsheet. So this slide shows the line list, starting with the ICU patients who met the suspected case definition during our chart review. When we mapped them out chronologically, we could immediately recognize that the first three lab-confirmed Marburg cases, which are highlighted here, these are the same patients I described earlier in the presentation. Next, we looked at the patient who had been presumed to be the index case, who was the 35-year-old man who was admitted originally for diabetic ketoacidosis and did not have fever on admission. His fever began more than a week later, suggesting that he may have acquired infection in the hospital. We then found who we call in this figure patient number 9, and she was a young woman who had been transferred to King Faisal from a district hospital after a cesarean delivery and had a diagnosis of malaria plus HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. Her stay at King Faisal was unfortunately brief. She was admitted to the ICU in grave condition and died less than 24 hours later, despite resuscitation efforts. But studying her chart revealed that she had been cared for in the ICU bed directly adjacent to where the 35-year-old man was working. And so that proximity was the key revelation. So we shared her information with the field epidemiology team to trace her exposure history, both to the district hospital where she had delivered and also to the community where she resided before that. So, and finally, the last thing I want to point out with this line list is a pattern that became clear as we reviewed the rest of these records, and that's that nearly every other patient in this series who did not have a link to Marburg infection did have malaria. And in retrospect, this frequency of severe malaria and its clinical similarity to Marburg virus diseases likely contributed to the delayed recognition of the outbreak. So we felt this was an important dynamic to share with the field. So Dr. Zainab, who's pictured here, and one of the team that I worked with, is leading our team in submitting a manuscript for publication to tell this story. To emphasize this issue more, I will show this figure, which shows the number of malaria admissions at King Faisal during 2024. And as you can see, the malaria cases were rising sharply over the summer, and it's something we're talking a lot about in the months that after I had initially arrived. So when patients presented with fever, anemia, and liver dysfunction, malaria was typically the default assumption for most of us. Even more, it's also worth noting that just a week before the outbreak was recognized, colleagues here at King Faisal and the University of Rwanda were discussing new research on anti-malarial drug resistance, here shown in a figure from molecular surveillance across multiple sites in Rwanda, an increasing prevalence of genetic drug-resistant markers. This was a really interesting scientific accomplishment that shed light on an emerging global health issue. So at the time, this malaria was where everyone's attention rightly was. So going back, what did the field epidemiologists learn when they investigated those pregnant women who died in the ICU on August 28th? Well, this figure here is trying to put everything together for these first 5 cases, and it shows the 2 cases I showed before, and then going backwards to the left, the 35-year-old the healthcare worker who was tested initially, and then the person formerly known as patient 0, which in this figure is called patient 10. And the field epidemiologists came back to us excitedly the next day, saying that they agreed with our suspicion that this patient 9, the pregnant woman, was the likely source of the infection and transmitted to the diabetic man in the adjacent ICU bed. And the crucial detail that convinced them of this came from what they learned about her husband. He had worked as a miner in a tunnel about 30 kilometers outside Kigali in an area known to harbor Egyptian fruit bats, which is, as I mentioned, the established natural reservoir for the Marburg virus. And during the interview, he had reported a febrile illness about 2 weeks before his wife's death. It hadn't been severe enough for hospitalization, and he'd been treated as an outpatient for presumed malaria. When he later provided a blood sample for serologic testing, it turned out it was positive for malaria virus IgG, which confirmed that he likely had prior infection and effectively closed the loop. So the evidence now pointed to a pretty clear sequence. There was zoonotic spillover from exposure at the mine, household transmission to his wife, nosocomial transmission to the ICU. And this chain explained nearly every confirmed case in these early clusters. So following identification of the mining tunnel as the probable source, an ecological field team was deployed to assess the potential reservoir for environmental contamination. And the approach to ecological surveillance involved the strategies shown here on this slide. First, there was risk-based geographic mapping. There were efforts to understand bat ecology and their movement patterns, which involved GPS tracking of bats around the region. There's also viral hemorrhagic fever surveillance in bats and other intermediate hosts. As you can see in the picture on the left, a bat getting swabbed for Marburg virus. And finally, there was community-based surveillance network and awareness campaigns. So new clinics were set up at the mining sites where bats were present so that if anyone developed symptoms, they could be tested in an expedited fashion. And finally, what we learned about this specific mining tunnel was that bats had long been known to reside there, and actually some efforts had even been taken in the past to remove them. Here on the right is our friend and colleague, Dr. Edson, who led the surveillance pillar of the response, investigating safely out of harm's way outside of the tunnel. And there's a timeline on the left showing that in the couple of years before the outbreak, the company had been taking efforts and trying to get advice on how to reduce the number of bats, understanding that it was a health risk. But the last finding shown, the lower left, is probably one of the most interesting pearls from the whole outbreak story, in my opinion. So in November, after the transmission had been controlled, the Rwanda team worked with the lab team from the US CDC to conduct serologic testing among about 140 miners who had worked in Tunnel 12. And it turned out that 13 of them had evidence of prior infection, meaning they were antibody positive, yet none of them had reported a prior illness consistent with Marburg virus disease. So this provided the first evidence that I'm aware of that Marburg infection might be subclinical and might be more common than we previously realized among people who are occupationally exposed to the virus. So let's now turn to what happened inside the treatment centers and how the teams approached care, therapeutics, and ultimately prevention. Before I discuss the various elements of the treatment center, I kind of want to start by showing the bottom line, which was the clinical outcomes from the outbreak. The overall case fatality rate was about 23%, which is remarkably low by the historical standards of Marburg virus disease on the African continent. When we look more closely at the data, we see a couple of interesting differences that stand out in terms of mortality. The top box that I highlighted here shows that patients with a low CT value on their initial PCR test, and CT value is a lab parameter, and low CT value indicates high levels of detectable virus. Among those with high levels of virus, 48% died, and that compared to only 5% of those who had a high CT value, which means a low viral load. And in the lower box, it shows that among the people who recovered, the median number of days between symptom onset and hospital admission was 1 day, whereas among those who died, it was 3 days. So while these aren't statistically meaningful comparisons due to small sample size and many confounding factors, the findings reinforce what we believe to be true from other filovirus outbreaks, which is that supportive care and rapid clinical intervention can dramatically improve survival, even before we consider the effects of antivirals and monoclonal antibodies. This is a picture of the first Marburg isolation unit in Nyamata, which is a suburb outside of Kigali. And this is where the first patients were transferred after testing positive for Marburg. It was activated on day 2 of the outbreak. Importantly, it wasn't built from scratch. It had been constructed several years earlier for use during the COVID-19 pandemic, and it was maintained in a state of readiness for future outbreaks. And that advanced preparation made a big difference. So within hours of the first Marburg case, the facility was cleaned and restocked and staffed to begin receiving patients. So functionally, it worked as intended, but it was not an easy environment. The temperatures inside were high, air circulation was limited, and the physical conditions were difficult for both patients and healthcare workers. Picture on the left here shows a healthcare worker drenched in sweat after doffing PPE at this temporary treatment unit. So while the Nyamata facility's rapid activation was an impressive example of readiness, it was quickly recognized as not an acceptable long-term solution for patients or staff. So the Ministry of Health acted quickly with this understanding, and within days it repurposed one of the largest private hospitals in Kigali to serve as a dedicated Marburg treatment center. And this new facility provided a safer, more sustainable environment with reliable electricity, oxygen, and air conditioning. You can see this much happier healthcare worker on the right, and it allowed the teams to focus on high quality and safe care for their patients. And here are some more pictures of the treatment center, which was hailed by Dr. Tedros, who is the WHO Director General, who visited actually several times during the outbreak, as the best he had ever seen. The case management pillar of the National Command Post, which was the area where I was able to contribute mostly as a project manager and consultant, it coordinated aspects of clinical care during the outbreak, and its responsibilities included finalizing and disseminating the national treatment guidelines, conducting daily clinical huddles to review each patient, and maintaining close coordination with the WHO clinical support team. The same group also managed and supported the implementation of research protocols for investigational therapeutics. 3 products were included under these types of protocols: remdesivir, the antiviral, a Marburg vaccine candidate, and a monoclonal antibody called NBP-091. I'm going to talk through each of these in the next slides. Remdesivir was the first investigational product that was used. It's a broad spectrum antiviral. It's originally developed by Gilead Sciences for hepatitis C, and then later repurposed for various RNA viruses, including Ebola and SARS-CoV-2, which, as we all recognize, for the COVID pandemic. And it was shown in preclinical studies to have activity against a wide range of viruses, which found its sort of second life after it was abandoned as a hepatitis C drug. So what we know about remdesivir filovirus infection comes from some animal models, but also from this large clinical trial of the PALM study, which was conducted during the 2018 Ebola outbreak in the Democratic Republic of the Congo. So PALM was a randomized controlled trial that compared 4 therapeutic agents head-to-head, including remdesivir and 3 different monoclonal products. there was no placebo arm, so all participants received active treatment. And what they found was that remdesivir performed significantly less well than two of the monoclonal antibody products, which showed the highest survival rates. So these results established a benchmark. Remdesivir was known to have some antiviral activity, but because it wasn't compared to a placebo, its efficacy as treatment was still unknown. But this evidence framed how Rwanda used it as a safe but potentially helpful component of comprehensive supportive care and a strategy in need of additional data. So how was it used in Rwanda? So it had not been used previously for COVID. So a large shipment of remdesivir vials were obtained very quickly after the outbreak was announced. It arrived in the country on September 28th and started to be administered to nearly all patients and became really the standard of care starting on September 29th. It was given as a 200 milligram intravenous loading dose on day 1, and then 100 milligrams every day for up to 14 days. Remdesivir was used in two distinct ways during the outbreak. First, as a therapeutic agent for patients with Marburg disease, as I just mentioned. A total of 52 patients received at least one dose as treatment. Among these 52, 3 died, which is a 6% case fatality rate. And by contrast, among the 14 patients who did not receive remdesivir, 12 died, or about 86%. So these are observational data, not from a controlled trial, so we can't conclude that there is effectiveness, but the observation was exciting because it suggested a possible clinical benefit and a clear improvement in survival over time as treatment program was matured. Secondly, remdesivir was offered as post-exposure prophylaxis for healthcare workers who had had high-risk contact with confirmed cases. And that effort was conducted under a research protocol with informed consent and ethics approval. And the findings were just presented this past Monday at ID Week. And it's a pleasure to be able to review that abstract briefly. So here's Dr. Sion Firu, who's our colleague and friend, and who serves as the chair of emergency medicine at King Faisal Hospital. She was the driving force, an important leader on many areas of the response, but took the lead to set up this protocol to use remdesivir among exposed healthcare workers. Importantly, it was not a controlled trial of remdesivir. This is rather a description of an emergency use case of remdesivir. It was administered to staff who were still working after having been exposed to the virus. Sion recognized that people were frightened and eager to take any reasonable measure to lower their risk of getting sick. She also noticed that we had plenty of remdesivir on hand, so she asked for my help in developing a protocol we could use to administer the drug as PEP, or post-exposure prophylaxis, and then also collect data systematically to learn as much as we could about the strategy later on. So this were the results that were presented this week. There were 380 healthcare workers who were determined to be exposed and invited to take a baseline survey, as well as given the option to take PEP. 51% opted in and 49% declined to take PEP. Most of the healthcare workers were under 40 and about 51% were male. Later, this was not part of the protocol, but when we followed up, 261 had reported being tested for Marburg disease during the outbreak, and 11 had tested positive and developed symptoms. 20 of them were hospitalized with Marburg-like symptoms, but not all have tested positive, and some were able to be released after 2 negative tests. Most of them incidentally had malaria. So this box and whisker plot, it illustrates one interesting observation from the data that Sion and her team analyzed. It compares the incubation period shown on the vertical axis here as the number of days between the first likely exposure to MVD and the day of symptom onset. And it compares this interval between MVD cases who received remdesivir as PEP in the blue box, and then the rest of the outbreak sample who did not receive remdesivir before they were tested positive in the red box. And as you can see here on the right in blue, cases who received PEP had a significantly longer incubation period than those who didn't. So this is an interesting signal that might suggest remdesivir slows viral replication, and that potentially if given for a longer course, it could be useful for preventing clinical disease. But overall, and this is actually one final element of the PEP project was to collect blood samples for Marburg virus antibodies among all the exposed healthcare workers. And whereas I just mentioned that 11 workers in the country or in the cohort had developed MVD and tested positive by PCR, the serology test that showed a number 15 had evidence of prior infection. So there were likely a few unrecognized MVD infections, and these occurred both in people who did receive remdesivir and also among those who didn't. Okay, moving on from antiviral drugs to the next investigation treatment. MBP-091 is a monoclonal antibody that was originally isolated from a patient who survived the infection. It targets the viral glycoprotein, which is the surface protein responsible for host cell attachment. It's developed by a US company, MAP Biopharmaceuticals, which had also produced the products used in the Ebola trial that I mentioned, with support from BARDA, which is the US Biomedical Advanced Research and Development Authority. In animal models, MBP-091 provided complete protection among lethal Marburg virus challenge when given to macaques shortly after exposure, and partial protection even when treatment was delayed. At the time that it was used in Rwanda, it had not been FDA approved. Only a single phase 1 study in healthy volunteers had been conducted. It showed no serious adverse events. And given that there were preclinical studies demonstrated some safety, it was an attractive candidate to be used in an investigational use. So in early October, MAP Biopharmaceuticals submitted an expanded access protocol to the US Department of it should be HHS, the Health and Human Services, also to the Rwanda FDA and the Rwanda National Ethics Committee. As these were under review, they shipped 5 doses. So there was not very much of this product in existence at the time, and they shipped it to Washington, D.C. on October 4th. And this box shows the expanded access treatment protocol of a single infusion given on day 1. So here are some actual pictures that we took. In the orange shirt in the upper right is my good friend and colleague Dr. Menelas, who was actually able to drive out onto the tarmac and retrieve the vials of the monoclonal body the night that it received. Drove it to the hospital. You can see him handing it off to Dr. Sion here, but handed it off to Dr. Lambert on the lower, the pharmacist who reconstituted the vials. And then the next day, after doing this work through the night, they were able to start giving it to patients. Overall, it was administered to 10 patients, 5 under the expanded access protocol, and then an additional 5 who were enrolled in a randomized clinical trial, which I'll describe here in a few slides, starting on October 15th. Of the 10 patients who received it, it might have been the first two who were gravely ill at the time that they received it had died, but the subsequent 8 patients recovered. Okay, moving on to the third investigational agent. It was a vaccine candidate developed by the US-based Sabin Vaccine Institute in collaboration with the Vaccine Research Center at NIH. It is a chimpanzee adenovirus vector vaccine called ChAd3-MARV, which expresses the Marburg virus glycoprotein. And the same platform had been used for Ebola virus vaccines. Before the outbreak, the vaccine had been tested in a phase 1 safety and immunogenicity trial in healthy adults, but had never been used in an outbreak setting. So there was excitement about the possibility of a viral vector vaccine for Marburg based on the results of this earlier Ebola vaccine trial, which I'm showing here, as was published in The Lancet. It was done in the outbreak in Guinea in 2015, used a similar viral vector platform of recombinant vesicular stomatitis virus expressing the Ebola glycoprotein. This trial was launched during an active outbreak under really challenging conditions, yet it demonstrated remarkably high vaccine efficacy, essentially 100% protection among those who were vaccinated immediately compared to those who had delayed vaccination. So it was an important proof of concept, led to a lot of excitement about using a similar strategy for Marburg virus. So given the impact of the Ebola vaccine trial and its subsequent licensure, there was a major goal to get experimental vaccines deployed as quickly as possible, and Rwanda was able to do this successfully. So CEPI is an organization called the Coalition for Epidemic Preparedness Innovations, which developed actually before COVID and after the Marburg or the Ebola outbreak, with a stated goal to have vaccines ready for use for initial emergency authorization within 100 days of identification of novel pathogen with pandemic potential. So this was very well funded by global donors, and worked with governments to try to create the infrastructure to do this. And Rwanda was the first country in Africa to formally endorse this 100-day mission, committed to strengthening their capacity to participate in vaccine development. So how did Rwanda do in view of this 100-day mission? Well, the answer was 13 days. Actually, even about the day before the Marburg outbreak was announced publicly, government leaders were contacting CEPI and the Sabin Institute for more information about possible vaccines. This trial, which I think I'm running short on time, so I won't go through every step, but shows how the various steps in terms of protocol submission to the ethics committee, getting the shipment, getting them pre-positioned in the places, and then ultimately starting to vaccinate healthcare workers was done in a total of 13 days. So while Rwanda was widely celebrated for its rapid coordinated response, there was one point of controversy that drew some attention in global health circles. I wanted to share it because I think it raises interesting questions about clinical research ethics in emergencies. And so the debate centered on whether Rwanda should conduct a randomized vaccine trial similar to the Ebola ring vaccine from 2015 versus prioritize vaccination of healthcare workers as soon as possible. A trial protocol had been developed in advance by WHO with a group called the Solidarity Partners, and they were recommending that they move forward with this ring vaccination trial. But the Ministry of Health declined in favor of vaccinating all frontline healthcare workers, and thinking that since they were at the front line, even though there wasn't solid efficacy data, they wanted to give everyone the chance to get protected as quickly as possible. And then the same Solidarity group had also developed a treatment trial designed as a 4-group factorial RCT, which was going to compare remdesivir and the monoclonal versus usual care. And this strategy was also pre-approved or pre-positioned for various filovirus outbreaks, and the Rwanda government approved this trial. And while it started late in the outbreak, there was a handful of patients that were able to be entered into this randomized control trial. So as we're nearing the end, I want to step back and think globally about the details of this outbreak. A few broader lessons stand out, and one of the most important one is the value of a One Health approach. One Health is the recognition that human, animal, and environmental health are deeply interconnected, in that protecting people from emerging diseases depends on strengthening all these domains together. The Marburg outbreak in Rwanda illustrated this vividly. So the chain of events began with a single spillover from wildlife, a miner working in a tunnel with bats, but it became a national emergency because of human systems, the interaction of people and hospitals and communities. And similarly, the response required attention to all 3 of these domains. It wasn't just about vaccines and antivirals, it's about building resilient systems that link public health with clinical medicine. And so as I believe and as I teach and talk about often, medicine and public health can't merely operate in parallel, they have to reinforce one another. And they do this when they're built on shared infrastructure, trusting partnerships, and a shared sense of purpose. So in summary, I learned far too many lessons during my sabbatical to fit on one slide or even in one PowerPoint presentation, but I wanted to close by listing a few points that I found especially impactful as a scientist. The first is that Marburg virus disease has probably a much wider clinical spectrum than we often teach, ranging from asymptomatic or mild self-limited infection to the fulminant disease that we're familiar with. And this broader spectrum matters for surveillance, for counseling, and for trial design. Second, early supportive care, fluids, electrolytes, organ support, as close to symptom onset as possible is probably the biggest determinant of survival. Third, antivirals and monoclonal antibodies likely have a role, but we need rigorous studies to show their true impact on outcomes. And we have to figure out how to balance the compassionate use of these promising therapies with the need for solid evidence I don't have time to go into this in detail, but it was actually really challenging to think about how to do a randomized trial that involves remdesivir when we had already been given to almost everybody as a matter of routine. So there were some difficult conversations among clinicians about, well, is this the right thing to do or not? Both sides have a valid argument, and I don't know the answer, but it's something that we need to think about carefully. Fourth, protecting healthcare workers before VHF outbreak is recognized, to me, remains an unresolved challenge. Clearly, in resource-limited hospital settings, we need to support and elevate the quality of routine infection prevention. And there's also challenges about in this gray zone. If there's not an outbreak, at one point with patients with severe disease, do we need to suspect Marburg and start this cascade and do testing? I think that playbook hasn't clearly been written yet, but we've learned a lot to move toward that. And then finally, preparedness is all about capacity. So VHF readiness requires clinical excellence, laboratory excellence, and strong public health partnerships working as one system. That's what allowed Rwanda to be so effective. And I'll say in closing that these are things that in our context here in Wisconsin, we do these things quite well. And faculty at universities like ours have a lot to offer our colleagues in low and middle income countries as they face these emerging public health threats. So at this time when our federal government is actively disinvesting in global health security, it was an extraordinary honor to be able to contribute so meaningfully to a country where health infrastructure is actively being strengthened. And I hope that by sharing my experience, I can inspire more of us in academic medicine to think about ways that we can help fill this gap. So I have too many people to thank and not enough time, but I wanted to say that this whole experience for me, which I found so meaningful, was only possible because of a great amount of support from leaders in our Department of Medicine. Dr. Schnapp and Dr. Andes were nothing but supportive, and the HIV clinical team, which helped cover patients, and everyone who really made this happen smoothly. Similarly, at DHS, our leadership, Kirsten Johnson and Paula Tran and Tracy DeSalvo, were supportive. They allowed me back after I took a year of absence and were eager to learn the things I was learning about preparedness. And then finally, the picture on the bottom is, in my objective opinion, the smartest, hardest working, and most compassionate group of researchers on our campus. And I should say that the work that we do in our NIH-funded research here at UW-Madison continued while I was away, and this team stepped up in a really admirable way, and I'm tremendously grateful. But most of all, it's these folks that I need to acknowledge and thank and honor. Dr. Mary ended her sabbatical 8 months earlier than she expected to, and became a single parent for our kids during what was a really stressful year for all of us. My kids here, Charles, Harold, and Nora, had to endure a lot of uncertainty and difficult transitions, and I'm extremely proud of them and grateful for their courage and understanding and support. And finally, this is a photo of actually a small subset of the very large team that worked together during the outbreak response, shown at a retreat in January where we conducted the after-action review. I'll forever be amazed by the dedication and courage of this group of professionals. It was a true privilege to be able to work alongside them and think and learn from them. So thank you so much. I'll stop there.
Thank you, Ryan. An amazing presentation. Actually, it gives us a perspective as to exactly in real time how this outbreak unfolds, and I mean the quick turnaround and the outcome. One thing to just maybe correct, when you were saying about the index cases husband, the real index case, finally, the one that we found, you said IgG to malaria was positive. I think it is IgG to Marburg. Is that right?
I'm sorry, I must have misspoken. It was and this was a new test that was helpful. That was brought in by the U.S. CDC filovirus lab, but and yes, it was positive IgG to Marburg. And there was actually a large serologic survey that we're still getting the results from of doing Marburg serologies, which was used for the remdesivir PEP cohort as well. So yes, he was the first one that we really was used in a really informative way to say that to sort of clinch the case. It was a Marburg case. So yeah, thanks for pointing that out. I must have misspoken.
Yeah, I knew that, but I just pointed out because it is recorded and people need to know that. There is one question that I see. It seems there may be a new role of routine surveillance of VHF in patients presenting with malaria. Has that practice changed as a result of this experience?
Well, this overlap between malaria and Marburg is certainly now recognized as a challenge. So the most clear thing that has happened is more of a clinical practice or a clinical education, in that there needs to be a higher level of suspicion for viral hemorrhagic fevers for among patients with severe malaria. What we need to do, which we haven't quite done yet, is to somehow translate that to a protocol that can be reliably followed at multiple sites. The second half of the year, I was able to help work as an ID consultant at King Faisal Hospital, and it was clearly always on our minds when a patient with severe febrile illness and abnormal LFTs was in bed, we would send the panel for viral hemorrhagic fever. But we're only going to find cases quickly if that's done on a routine basis, because there's no reason that says, in fact, it's probably more likely that the next Marburg case is not going to come to King Faisal Hospital. It's going to be at a district hospital. Typically, these outbreaks occur in rural areas, which is why why the outcomes are so bad, because there aren't resources there. So this is, and Rwanda is in a great place to figure out to do this because of the way they're integrated. But we need to develop some sort of protocols and use these multiple surveillance methods, potentially the environmental surveillance methods, to know what seasons there's some seasonality to where when the bats are most infectious, early detection using environmental surveillance and other sources to say that at what point does our suspicion of viral hemorrhagic fever go from baseline, which should always be non-zero, to elevated, where we might need to do something differently, like have a lower threshold to send the PCR test. And then the other thing that's challenging, that Rwanda has good resources, but throughout the region it's not the norm, is laboratory capacity to actually do the test quickly, transport the specimens, and get the results back quickly. So a lot of lessons learned about that first step.
Yeah, great. So a number of shout outs, by the way, here from UW and also from Rwanda, and I will try to copy them and send them to you. Another question from Dr. Schnapp. What was the turnaround time for Marburg testing, and was the testing done in-house or a send-out lab?
Yeah, great question. I didn't have time to talk about that, but one of the improvements, or one of the development things during the outbreak, was at baseline before the outbreak, the National Reference Lab, which is similar to our in Wisconsin, we have the State Public Health Lab of Hygiene, which is the one that does most specialized tests, and then there's a few that they have to send out to CDC. In Rwanda, the National Reference Lab can do the filovirus outbreak, and they were able to do the test with a 24-hour turnaround time. During the outbreak, and this was a huge success that I actually learned about at this after-action review, is that they were able to build a network and decentralized Marburg virus PCR to be done at 5 labs around the country, and the goal was to have less than 24-hour turnaround time. So that was capacity that scaled up during the outbreak. It was actually pretty good. So they were able to do the PCR tests in the country, and had a good network for getting specimens transported. And it was an advantage of having a really geographically small country with good transportation, excellent roads, which I think made a big difference.
Right. Another question from Miriam. How many healthcare workers were exposed, and is it possible that there was respiratory spread of this disease, or many episodes of blood fluid exposure? Healthcare worker.
Yeah. The best data that we have about the number exposed was from actually Sion's abstract. We had a rough sense of who was working, and the HR helped look at a grid, like who was in the unit or on the ward when one of these patients was being cared for. So we actually recruited, made a wide announcement for people that worked in those spaces to sort of self-identify as being exposed, as well as anyone else who thought there were. And in her cohort, there were, between the 2 main hospitals at King Faisal and the University Teaching Hospital, there were 380 people who were self-identified as having worked in those areas, participated in the study. And of those, as I mentioned on the slide, 11 tested positive later. So after they got PEP, and they were probably incubating virus at the time that they received PEP, went on and had symptomatic disease and tested positive. But those antibody tests, the serologic tests, the same ones that used for the minor, actually showed that there were 4 additional cases that weren't known. They didn't necessarily have symptoms, and was a sign that maybe there was, I don't know, silent spread, but maybe silent infection, silent or mild infection that wasn't initially detected. So, and whether the antiviral played a role in suppressing symptoms, I think we still don't know. And that wasn't necessarily the goal of the remdesivir trial. It was really to just give everybody the best shot they could to be safe and be protected. And I think it was a remarkable logistic feat to get 150 people treated with remdesivir, and hoping that it did some good for those who were exposed.
Yeah. So we are right on time. There were 2 questions, but we have to stop here for the interest of time and others. So thank you again, everybody, for joining us to this remarkable grand round, and it will be recorded, as I know. So thank you, Ryan.
Thanks, everybody.